Digitorum.
No.
Okay. So I am totally in the way of the camera. That should be better. So remember here, I always like knowing the order of what everything goes in. So tib posterior is going to be the one wrapping most tightly to your malleolus. What's going to come after that?
Digitorum.
Well, what's in between? What's after? So you have Tom, Dick, and then
Very nervous Harry.
So you're gonna have Tibialis posterior, Flexor digitorum, and then the artery, vein, nerve, and then it will be Hallucis. So Hallucis is definitely always going to go around that sustenaculum tali, whereas posterior and digitorum tendon should be a little bit closer to the malleolus. So if I have her mostly just kind of flex your toes down, yep. I would feel that tendon would be next, and I would probably try and follow it a little bit more inferior. Go ahead and relax. And go ahead and flex the toes again. And then I feel that contraction right around here. And then you can go ahead and relax. The next thing I would look for would be the tib posterior, or the posterior tibial artery. And I want her to be nice and relaxed for this. And just like with your dorsal pedis artery, you don't want to press too hard because you don't want to occlude the artery. And I might go a little bit kind of superior. I might go a little bit more inferior. Did we find yours in PCM?
No, I don't think so.
Don't think so.
Found Chandler's though.
We found Chandler's. Is that why you rushed up here to block Chandler to make my life harder?
Yes, that's exactly what I wanted to do. My goal for today.
So like I said, I feel like everyone's a little different. Some people, this one will be really hard to find. And some people, the dorsal pedis will be a little harder to find. And I'm getting it very, very faintly right here. And then again, I'm gonna make sure I come off her malleolus. You don't have very bony, or you don't have very prominences. I believe this is her sustenaculum tali here. So then if I come just off of that, go ahead and flex down, and then I feel a little tendon pop up right there around the tali.
Pushing between the subunguitalis.
I am inferior.
Right here. Okay.
So
right here,
tali is right here.
Because it's the pulley.
The malleolus is here. So tib, posterior, and digitorum, and the nerve, artery, and vein are all going to be here. And then the tali is here. And then flexor hallucis is wrapping around that tali. And then I believe we can go prone for everything else. And yeah, slide down so your feet are just off the edge. So Gastroc Soleus complex, you have your lateral head of your gastroc, your medial head of the gastroc. You can usually palpate down in between the two. This is a really great place to do some soft tissue and work on the fascia that kind of separates them. And then as we get down around here, as everything kind of thins out, this is a very common area of injury. This is the Musculotendinous Junction. So inferior here, attaching to like the posterior calcaneus tuberosity, would be your Achilles tendon, would very specifically be this long, skinny, ropey part. This is another mobilization technique you can do, where you're kind of like bending the tendon. Any tenderness there, patient? So sometimes there'll be injuries here. This would be more like where you would find your tendinitis. Sometimes you'll get like an avulsion fracture where the tendon attaches to the bone and it can actually start to rip the bone off. Sometimes this prominence will start to kind of stick out a little bit. I believe there's a particular name for that disease. Osgood-Schlatter's is the knee, so it's called like osteochondrosis, I believe is the term. So if it's in your anterior knee on your tibial tubercle, that's the most common one in like younger kids. That's called Osgood-Schlatter's disease. Throws off the length-tension relationship of the quads. So doing a lot of like quad mobility work to reduce the tension there. Same thing with this one. Reducing tension in the calf muscle can relieve tension on the bony attachment and decrease the likelihood of that little bony growth to increase. And then for soleus, you would kind of come off of the gastroc and kind of work your way under the gastroc, and then you can get on soleus on either side here. This wouldn't be a specific palpation that we would have you guys do in class for the practical because it's just really hard to differentiate between those two. But you should still definitely know, like if I wanted to work soleus more, you did your MLTs that will go over, and you feel like the soleus is more of a problem than gastroc, then I'm not going to push through gastroc as much. I might try and come under and get to soleus there. And then, did I talk about the musculotendinous junction? Okay, so that's another area where like you're more likely to like maybe see like a tear at the musculotendinous junction. And then on the bottom of the foot, we have our plantar fascia. So I'll bend her knee slightly to put gastroc on a little bit of slack. Plantar fascia is going to attach on the bottom side of the calcaneal tuberosity here, and it's going to run down the whole foot. The largest piece tends to be if we extend the big toe. And then if you go ahead, just contract your big toe. So there's your your flexor hallucis tendon, and then this piece here that just comes up that's going to be her thickening of the plantar fascia. But the fascia runs through the whole bottom of the foot, attaches to all the toes. So this line here might tend to be quite tender, but you can get tenderness in the whole area. And that's another common area of problems that you work with people. Did I miss anything? Peroneus tertius. Okay, you have to go back. Supine forming patient. And let's use your other foot so that they can. So Peroneus tertius is going to be another small one, a little bit more anterior, and I didn't do the muscle belly here. Okay, so you are going to dorsiflex and evert. So Peroneus tertius is going to be this tendon here. Again, very small muscle that starts kind of distal out here on the fibula. And then if you dorsiflex and invert would be your confirmation for the bigger anterior tibialis muscle belly. We talked about the tendon, but we didn't talk about the muscle belly. So that's going to be along this whole aspect of the anterior tibia here. And that's the big muscle in your lateral compartment of the foot. Any questions? All right, let's go ahead and practice.